Next, I'm going to introduce Dr. Miravalle. And Dr. Miravalle came here today also. He's from right across town. And even though he gave me something long and very small to read, I'm going to try my best here, right, without my glasses. So Dr. Miravalle is an associate professor, associate chair of education, and chief of the multiple sclerosis division at the University of Florida College of Medicine. He specializes in multiple sclerosis and related neuroimmunological disorders of the brain and the spinal cord. Dr. Miravalle has been involved in both clinical and science-based research. He's a member of many professional societies and advisory boards. He has published numerous scientific articles and served as a consultant to various scientific organizations. Dr. Miravalle was the recipient of the 2012 American Neurological Association Medical Education Fellowship Award. Let's welcome Dr. Miravalle. Thank you, thank you.
Thank you. All right, thank you for the wonderful introduction, and thank you, Jeff, for your very dynamic presentation. I've been in many presentations before about exercise, and certainly this was one of the best ones. I love seeing you demonstrate how to exercise. That actually reminded me a funny story I had when, 4 years ago when my son was 4. And I recall buying him a small Lego set, and he was very excited about that. And he's like, "Daddy, let's do the Legos together." And I told him, "Okay, tomorrow we'll do it." And tomorrow came, and I worked very late, so I couldn't. And then the next day he said, "When can we do the Lego set?" "Promise, buddy, tomorrow we'll do it." And that day, of course, was a long day at work, and I came home at 8, and he was already in bed. So as I parked the car, I went to his room. He was half awake, half asleep, and I gave him a hug. And I just said something that I should have probably been thinking, which is, Matthias, what is important in life, right? So what I was thinking is, priorities and working too much and not playing with my son, and what is important, right? So I said that out loud. And he opened his eyes and looked at me as he knew the answer from the beginning. He says, "Exercise is important, Daddy." So that made me smile, but actually the message is that even at that age, they know that exercise is important. And in MS, Jeff is right, exercise now has evidence behind that not only makes people feel better, but actually makes MS better. And the clinical outcomes over and over show that anywhere from brain atrophy to certain symptoms like depression, for example, and fatigue improve with a regular routine of exercise. So what I thought to do today with you is review a few of the most common questions that we encounter in the clinic from our patients, which is anywhere from why do we need to be on disease-modifying therapies? How do we know that these therapies are working? What is the process of selecting the right therapies? Well, now we have 17 approved medications in multiple sclerosis. And how do we choose which one is the best? And most importantly, once you choose one, how do you know that this therapy is doing the right thing for you? So to start, I thought to go through some cases. And this is a patient that perhaps reminds you of some of the elements that you went through in your diagnosis, which is a 22-year-old female presenting with speech problems. We call that dysarthria, double vision, and loss of balance. And on the examination, the patient has some incoordination and some misalignment of the eyes. And we do an MRI, and as you can see here, the patient has multiple white dots in the brain. Those are the MS lesions. And you can also see that the patient actually had an enhancement when you do the gadolinium. You can see this lesion that actually takes some enhancement on the periphery. And perhaps all of you had an MRI, I hope, at some point, and all of you had also contrast with the MRI. And you may or may not know why we do that. Well, this is one of the reasons. If a lesion takes in contrast enhancement, that means that the lesion is new. And new on MRI is anywhere between 1 day to 4 weeks. So when we see this lesion, we immediately think, well, this is a brand new lesion, and that lesion occurred anywhere between now and 4 weeks ago. So this is kind of like a way that we use to understand, is this lesion a new one or old lesion? So this patient was diagnosed with multiple sclerosis. And we have now the 2017 criteria, was recently published in November, that allow us to diagnose MS patients with actually even one MRI when possible. When that patient had one clinical event and one MRI, if there are the right things present on the MRI, we can make that diagnosis pretty quickly. And the importance of that is that the longer we delay the diagnosis and, of course, the treatment, the lower our chances are to make an impact with these therapies. So there is a lot of emphasis in the MS community to make that diagnosis accurate, but also early. And you can see here that the lesion actually not only looks white, but if you look carefully, there is a black line in the middle. Can everybody see that black line there? Over here, so you can see the lesion, and in the middle there is this black line. And if you see that in your MRIs, that's very typical for MS, and that's something that we call the central vein sign. So what you see here as dark is a small little vein, small little vessel. And what it tells us is that demyelination, which is this white signal that you see on the MRI, occurs around the veins. And we believe that that's the way the immune cells are getting into the brain, something that we call perivenular demyelination. And you can see that the lesion actually follows the vein around. So this is very, very specific for multiple sclerosis. So the big question here becomes, and I did this presentation to a group of neurologists not too long ago, and I asked them, so what therapy would you start with this patient? And I gave them these options: high-dose interferons, cladribine acetate, orcopaxone, fingolimod, and alemtuzumab. And to my surprise, there was 20% on some of those, 30%. So the answers were very broad and very different, and they were all neurologists. And that tells you that still we are not there yet to have some sort of consistent approaches in terms of how do we choose the first therapy, how do we choose the right therapy for our patients. So this is a chart that comes from a variety of studies that actually showed us what are the clinical predictors that we can identify early on that can tell us something about what is going to happen in the future. We understand that every patient is different, and that is very true in multiple sclerosis. It's very difficult to say if we have a 22-year-old patient with an optic neuritis next to a 25-year-old patient with an optic neuritis, who is going to do better and who is going to do worse. We don't know that. But there are certain factors early on that we do know that are associated with worse clinical prognosis. And those factors are listed here. So we know that the time in between the first clinical event, that we call that clinically isolated syndrome, the time in between that event and the second event, so the shorter the time, the worse the prognosis. So patients who had more than 2 relapses in the first year, they tend to do worse. And that's something that we usually take as a red flag. In addition, we look at MRIs, and there are things that actually we know that carries a worse prognosis. So a large number of lesions at baseline. So a patient that presents with an optic neuritis and you do an MRI, and that patient had 15 lesions. Well, that patient probably is going to do worse than a patient who had 5 lesions. But the number is not as important as the frequency or the severity of accumulation of lesions. Let's say you do an MRI in the first presentation and you repeat that MRI 6 months later. The patient who started with 5 lesions perhaps does better than the patient that started with 15. But if the patient that had 5 lesions at onset, when you do an MRI 6 months later, has 25 lesions, whereas the patient that started with 15 has 17 lesions, the patient that accumulated more lesions will do worse. So the number is not as important, even though it is important, but perhaps the most important factor is how fast these lesions are developing. So we look at those things. We look at, for example, the presence of brain atrophy, which is shrinkage of the brain. And most of the time, we don't have ways to quantify brain atrophy. We can't tell patients an actual number, but we can look at the brain, and we can look at the brain over time and see whether that changes. And patients who have brain atrophy at baseline or at any point in time, we need to be careful because we know that that's a bad prognostic factor. How many of you know what a black hole in the brain is? Okay, hopefully by the end of today you all know, because that's important. So black holes are those lesions that look dark on the MRI, and we have ways to look at those lesions. So black holes are indicative of a deeper amount of damage in the brain. So look at the brain as a group of nerves, and each nerve is like that wire that you see here. So myelin is equivalent of the plastic around the wire. And myelin not only protects the wires and protects the brain cells, but actually is where the information travels in the brain. Axons are inside the myelin, and that's equivalent to the copper wires. So when somebody has a white dot in the brain, that means that there is demyelination or loss of myelin. When somebody has a white dot and a black hole, that means that not only there is demyelination, but also there is axonal loss. So it's almost like cutting that nerve. So black holes are lesions that actually we try not to see and we try to prevent. And patients who have more than 30% of the total lesions being black holes, that's a bad prognostic factor. Gender, race, those factors are also indicative of perhaps different prognosis. We know that males tend to do worse than females with multiple sclerosis. We know that black tend to do worse than patients of other races. We know that Hispanics, for example, they have a lower risk of multiple sclerosis, but once they have MS, they tend to have more spinal cord disease, which naturally brings worse clinical prognosis. So those are things that actually we pay attention. Any questions? Okay, the question is, what is the difference between a spinal cord lesion and a brain lesion? This is a great question. Like in real estate, in MS, location is very important. And there are certain areas in the brain that has more redundancy in terms of the function. When you go all the way to the upper part of the brain, it's like going to rural Florida, okay? So there is a lot of space and there is a lot of redundancy. And imagine that when you see a lesion, you're blocking one street and you're stopping traffic. Well, if you live in Gainesville, you know that if you stop Archer Road, that's a disaster, right? Particularly in rush hour. So Archer Road in the brain or in the spinal will be the spinal cord. Whereas if you stop some small street in the middle of rural, I don't know, Palatka. I'm still trying to find learn my geography here. Maybe it's not a big deal. People can go around that, okay? So lesions in the upper part of the brain, they tend to have better prognostic factor. There's a lot of redundancy, a lot of opportunity to remyelinate around that. Whereas lesions in the spinal cord, they tend to be more symptomatic and more difficult to remyelinate. That's a great question. All right. So moving on, I think we cover the question of how do you know what drug to start? What are the clinical factors that you look for in an attempt to identify predictors for future prognosis? Whatever you choose, it has to be a shared decision, and that's always something that we emphasize. The best therapy for you is the one that actually you are educated on, that you know all your risks, all your benefits, and it's something that we predict that you actually will tolerate. Okay. So this is just to show you of one of the therapies that we have approved, which is fingolimod, that actually the way these drugs are studied is comparing the drug to placebo. And you look at how thousands of patients respond to this medication versus patients receiving placebo. And you look at different outcomes. In this case, the outcome was brain volume. And you can see that in the line that has those white triangles, those were patients receiving placebo, whereas the lines that has the black triangles, those are patients receiving the medication. And the lower you go here, the more brain you lose. Okay, so the closer you are to here, the better. And all of us here, with or without MS, every year we lose brain. That's part of normal aging. Okay, and males, we lose brain faster. So the rate of normal aging in terms of brain loss is 0.2 to 0.4% per year. So that's with or without MS. We all lose brain. Patients with MS who are not receiving therapies, we estimate that the brain atrophy rate is approximately 1% per year. depending on what therapy you're receiving, you may bring that all the way back to normal aging. And some of the highly effective therapies are showing rates of brain atrophy that are almost identical to normal aging. Patients on highly effective therapies who exercise, they do actually better than patients without MS who do not exercise. So that tells you that there is a synergistic effect of exercise, lifestyle modifications, and highly effective therapies. So here's an example that patients receiving, fingolimod in this case, but virtually all of the drugs that are approved showed benefit on brain atrophy, actually lose less brain than patients receiving placebo. Okay. And that brings the point. So what is the goal for our therapies? What is the goal for what we do? Our goal is to make sure that MS in your life is just that. A title, a label, something that you said, I have it. But that disease does not affect your life, does not affect your quality of life, that you go through life in the same way that you would have gone without multiple sclerosis, whether it's by preserving your brain, whether it's by enhancing your health, whether it's by taking care of your symptoms. We want to make sure that MS is a label that only you know or the people that you decide to share with, but it's not something that's going to be in your way. So this is another example that I want to show in terms of these benefits that every drug actually has are more effective the sooner you start in the disease course. And this was a study looking at the same effect on the same medication that patients who actually had a lower EDSS, which is a scale that we use in MS for disability. Okay, so that's a number that we can do after we do an exam. And by the way, in our clinic, we are doing EDSS in every patient every time. So if I didn't tell you your EDSS, you can ask me next time I see you, or Dr. Yang, who is here, and we can share with you what your score is. And we follow that over time. So patients who had a low EDSS, meaning low disability, they actually did better when they received this medication than patients who had a high EDSS. And what that tells us is that the sooner you start with these medications in your course, the higher your chances of getting all the benefits that these drugs are supposed to give you. Okay? But even when you start these medications here, which is in the later phases of the disease, there is still a benefit that is there. So we always say there's always something we can do for every patient with multiple sclerosis. It's never too late. So there is always a benefit, but that's something that we evaluate on a case-to-case basis. So moving on, so this is just to show you the amount of monitoring that we have to do with particularly this medication. And if you are a patient in our clinic, you know that we have a patient safety coordinator. That's one of the first team members that we hired in the team, because we, Dr. Yang and I, we are very careful about safety. We want to make sure that if there is any potential risk or harm that we can do with these medications, that we have a way to screen and to mitigate. So every patient on this drug, for example, has all of these labs done and all of these pointing times to make sure that we carefully look for and monitor for any potential complications. And we have the same screening process for every approved medication. They look differently to every medication, but we have those processes in place.
Dr. Miravalle, are you saying that everybody should be on some kind of disease modifying?
That's a great question. So the question is, does anybody and everybody have to be on a disease-modifying therapy? And the answer is no. We do know that certain patients with MS, for a variety of reasons, the perceived benefit of the medication is lower than the potential risks. An example of that being a patient with MS who is very advanced in the disease process, a patient who is over 70 years of age, a patient who has already bladder problems and frequent infections, frequent UTIs. And perhaps in that patient, if we start a medication that is a powerful immune suppressant, we might be bringing the complications of more UTIs and more infections without the perceived benefits.
So you're saying that over the age of 70, that they're not as effective?
That is a very difficult generalization to make because, as we mentioned before, every patient is different. So I had patients who, at the age of 72, we did an MRI expecting no change, and here you have an active enhancing lesion, and that patient had to go to a therapy. But there is a true trend that is happening in patients with MS, which we've seen that for decades. There is something called immune senescence. And what immune senescence means is that as we age, our immune system also ages. And after our 60s and 60s, the amount of inflammation from this immune system goes down just by aging. So the likelihood of people having active inflammation in their 70s, it's lower than somebody in their 40s. All right, any other questions?
Wait. If you have a patient that came to you and the very first symptoms that they had was their eyes, would you still do an MRI like on their spinal cord?
That's a great question. Yes, particularly if a patient has an optic neuritis, which is inflammation on the optic nerve, on the eyes, a brain MRI and a cervical cord MRI is very appropriate because we want to look for lesions elsewhere that can give us a sense that this is not just a problem on the eye, that this is something more like multiple sclerosis. There are other conditions that can present with optic neuritis, something that is pretty frequent actually here in Florida. It's neuromyelitis optica, or Davick's disease. And that's the usual differential diagnosis that we consider in the clinic. So yes, we often do that. All right, so I think it's time for dessert. So moving on to another concept that I want to present, which is something that perhaps it's more recent to you. When do we change therapies? Why do we decide to make that change? Okay, and let's say you're on a medication X, and all of a sudden you go to your doctor, and he or she tells you, well, no, we need to move on, we need to change. What are the frequent reasons? Well, the number one reason is usually something driven by you, telling us, I don't like the side effects, I don't like taking this medication, it's causing me a lot of trouble. And that's an easy one. We'll move on to something different. Second one being something that we perceived in our screening for safety. Perhaps the classic example being patients receiving natalizumab or Tysabri, who all of a sudden become positive for a virus called JC virus. And that is usually something that triggers that conversation. Do you need to stay here? Your risk of infections, or something called PML, it's higher, so we usually use that as a reason to change. But what about patients that has no side effects, no safety concerns, and they have no symptoms or no worsening? Why do we change? So this is a case that I actually also presented to a group of neurologists, which is a patient like that, a 45-year-old patient that had MS for a while and has been on interferon therapies, comes to your office for regular checkup. Some findings on the examination, but these findings have been stable for 5 years. And you did an MRI for surveillance, and the patient had 3 new lesions, but those lesions didn't have any symptoms associated with it, something we call asymptomatic lesions. So the question is, do you change therapies? Do you stay on interferons? What do you do? And I asked this question to the group, and again, I got a very broad answer to this question. Some opt to stay on interferons because the lesions are not causing symptoms. Some thought to check interferons antibodies to say whether are you responding against your interferons, something that we don't longer use. Some thought to change to Copaxone, and some thought to change to ocrelizumab. So what I then presented to them is a list of studies that now we do have that consistently showed that if patients are having lesions, whether they have symptoms or not, we should pay attention to that and perhaps change therapies. The presence of new lesions should be seen as treatment failure. And there is still controversy on how many lesions are too many, right? But the overall concept is accepted already, which is if there are new lesions on follow-up MRI, we should pay attention to that, and at least that should trigger the conversation on what's next. And sometimes you can change and sometimes you can't. Sometimes you're in situations in which patients already used every possible single option that is available, and well, there are not that many options available, but at least the presence of lesions should trigger the conversation with your doctor, okay? And most of the time we can find something. Whether you look at contrast-enhancing lesions or non-enhancing lesions, spinal cord lesions, no matter where they are lesions, and that's the tip of the iceberg. Okay, so that should be something that hopefully you're discussing with your doctors. Any questions? You've been very quiet. There's a question there.
Am I understanding correctly that different therapies are prescribed based on where the lesions are located, whether they're active or inactive, whether there are black holes, and the type of disabilities that are being experienced? Are there some therapies that are more effective against different problems?
Great question. So perfect segue to the next section, which is, you already established the diagnosis. Perhaps you chose the first therapy based on the perceived safety, efficacy, the tolerance profile that you chose with your patient. But let's go back to the first concept. Let's say that you have a patient that has all of those bad prognostic factors, right? So he's male with spinal cord disease, with multiple symptoms, multiple relapses. You think that this patient may get into trouble in the future because of all those factors. So the usual conversation will go around, well, if we have now 17 approved medications, and when you look at comparing these medications with each other, even though there is no consistent data around that, but you can see trends that there are three groups in terms of efficacy, right? The highly effective therapy group, that's usually that when I draw the line or the drawings with my patients, I put the 3 tiers, and tier 1, highly effective therapies. These drugs consistently showed in clinical trials that they have a very good chance of stopping new lesions or preventing new lesions from happening, on preventing brain atrophy from happening. Those are the medications that are usually IV medications, right? You have in this category ocrelizumab, you have natalizumab, you have alemtuzumab. And in this category usually is considered highly effective therapies. Then you have, on the other end of the spectrum, the low efficacy medication, the old injectable medications, right? So those are the drugs approved in the 90s, and back then were great because that was the only option. But now we know that they fall under the low efficacy medication. And they, as a group, they have approximately a 30% chance of decreasing the likelihood of new lesions. Whereas you compare to the highly effective therapies, you're talking about over 80% chance. Okay, so you have the two ends of the spectrum. And that for all patients. Those numbers come from thousands of patients, whether it's males or females or African American or white, that doesn't matter. Those numbers come from these large studies. And then you have the middle of the range, those tier 2 category, and those are your oral medications. And there they have some even variation within that tier 2. So the question becomes, how soon do you go to tier 1? How soon do you pull the trigger and say, I'm going to use highly effective therapies? And that's a conversation that usually happens individually between a patient and a physician after patients understand the risks, after patients understand the benefits, and saying, do we want to start with highly effective therapies from the beginning and maybe prevent as much as we can the next relapse? Or do we want to go somewhere in the middle, and maybe this medication is enough for you and you don't have to go to these infusions? So as far as I know, there is no differentiation between location of lesions, whether one drug is better for spinal cord or not. In general, we look at lesions as a group. That was a great question. So here I have hopefully a slide to I'm sure you will know this better than my colleagues, but actually lesions drive atrophy. Okay, so we know that, again, if we want to prevent brain atrophy, even if you can't measure that on an MRI, patients who actually have more lesions, they're actually more likely to have more brain atrophy as well. And this is our goal, something that we call NEDA, or no evidence of disease activity, meaning no more relapses, no more progression, no more MRI activity. That should be our goal. And most of the time we can accomplish that goal, sometimes we can't. But even if we can't, at least we aim for NEDA, we aim for nothing more happening to you, no matter where you are in the spectrum of MS. That's usually a conversation that will go about, let's do the best we can. Let's choose the best therapy, the best exercise program, the best diet, something that actually together might help you get there. How am I doing in time?
You have time.
I have time. Oh, that's bad. Boy, I have time and a microphone. You are in big trouble. I will...
We'll do another 10 minutes and then you ask for just all Q&A.
All right, that sounds great. So I have here, perhaps you all heard about the new kid in the block, ocrelizumab, approved for also primary progressive multiple sclerosis. We were very excited with that. The drug is a newer version of a drug that has been around since the 90s called rituximab, so they are very similar. Even though it is a new medication, we are somehow confident that we don't anticipate a lot of surprises when it comes to safety, because we learned quite a lot from his sister drug, rituximab, in the past. But that was a study looking at, so this is a combination of all studies, the phase 2, the phase 3, 2 studies for relapsing, as well as the primary progressive. And you can see that there was a significant reduction in relapses, a significant reduction in disability progression. You can see a risk reduction of 40%, as well as reduction in number of lesions at the level of 98%, which is very high. So patients receiving this medication had a significantly less chance of new lesions over time. So this is an example of a highly effective therapy that we often discuss with our patients in terms of what is the higher chance that we have to accomplish that outcome that we were discussing before. This is just to show you some meta-analysis of multiple clinical trials looking at one outcome, which is number of relapses over time, and how these drugs compare to each other. So the closer you are to this end, the better the outcome is. The closer you get to this line, the worse the outcome. And you can see these green triangles that actually shows that where the middle of the patient, the mean of the patient sample look like with the confidence interval, and you can see anywhere from alemtuzumab, natalizumab, ocrelizumab, all the way to the interferon. So this is a way that you can look at comparing different trials over time. These analyses are usually very noisy, because you're talking about trials here that were done in the 90s versus trials that were done recently. So the type of patients enrolled in those trials are different. Now that we have so many options, the patients that we enroll in trials are usually very benign, and they are okay taking the placebo risk, or they are very aggressive, and that's the only option they have. So the type of patients enrolled now are different to the type of patients enrolled in the 90s, but taking all of the differences aside, you can see that there is some variation in terms of benefits from these medications. And with that, I perhaps want to show you the third patient, the third and last case for today, which is a patient with primary progressive multiple sclerosis that has activity and progression, a patient that is actually getting worse, a patient that tells you, currently I'm only able to walk with a walker and only for 20 feet. 2 years ago, I was able to walk without any assistance. So that's an example of progression. And I gave the same to the same audience these answers, and the answer is, what would you do with this patient? Well, just focus on symptom management, because we don't have any approved medications. Start highly effective therapy, treat with steroids, talk about ocrelizumab, or start Copaxone. And the correct answer in this case is start, or at least talk about ocrelizumab. This is the only drug actually that we have approved for primary progressive multiple sclerosis. But the truth is that regardless of what you decide to do, let me just come to the end here. This is just to show you that we do have data in terms of progression. Decided what you decide to do, regardless of that, the main outcome, the main goal for this is to prevent the things that we can measure, which is atrophy, lesions, relapses, progression, but to improve the things that are hard to measure, which is quality of life. How do you live your day-to-day life? How are you dealing with fatigue? How are you dealing with depression? How are you dealing with, problems at work, attention, multitasking, irritability, your personal relationships? And those are the things that actually are hard to measure. And we are trying, and Dr. Yang is taking the lead in our team to do something that we call the Patient Reported Outcome Project, or PRO project. And hopefully you can all enroll into this study. That all it is we ask you to fill some questionnaires. You can do that online. You can do that when you come to see us in clinic once or twice a year. And we are hoping that with this project we can get to know more about you. Not only how many lesions and block holes you have, but we want to know how are you dealing with your fatigue, with your spasticity, with your pain, and try to quantify that, and most importantly, follow that over time so we have a better idea of how are you doing overall. So that's equally important. And with that, perhaps what I can do is present the team, and this picture keeps changing. As you probably know, we went from 0 to this in a year. Here in Gainesville, it was an incredible amount of work, but we are very happy with the accomplishments. We have one more faculty member joining us in July. He's an MS-trained physician. He's finishing his fellowship in Stanford University in California and coming here to Gainesville. Of course, Dr. Yang, she's been here now with us for 8 months or 10 months. And then we have 2 fellows that are being trained starting July 1st. One fellow is doing multiple sclerosis. She's coming from Temple University, and she will get her training here. And the other fellow is going to be doing a 2-year research fellowship in MS, and he's coming from Brazil. So we are very happy with the team. We keep growing. And of course, we have our wonderful physical therapists. We have occupational therapists, researchers, and perhaps somebody had a question on exercise program here in Gainesville. We do offer exercise programs. Those are free of charge to our patients. They are done in the senior center, right? Thierry, we can give you some information where to go. We are starting those in April. And we also are starting dance studio for our patients with MS. It's a great way to exercise and to socialize. So stay tuned. If you have any questions, we'll be happy to give you details about that.
Thank you, Doctor. Thank you for coming here today. Everybody give him... So don't run away yet. Does anybody have any questions for the doctor about anything to do with multiple sclerosis? And if you don't, I'm going to start it off, all right? Oh, there we go. I could always trust Nancy.
Gabapentin. When I read the contraindications of gabapentin, it's very scary. Suicidal thoughts. How prevalent are those contraindications? Is it something to be majorly concerned about, or are they rare, but when they do occur, of course, suicide is a pretty drastic contraindication. There's no returning from that one. How do we reconcile ourselves to taking that type of drug without worrying about all of the other problems that it could result in?
Yes, so those are serious side effects, and we should be careful and we should be mindful of the chances, because those are real side effects. Any intervention we do in medicine, there is a potential risk, whatever we do. And I think the key is try to be educated on that. And of course, as you can imagine, there is so much we can do in clinic to explain every single possible side effects. I don't know if you've ever seen the potential side effects of Tylenol, and it's the same thing, right? And we take Tylenol without thinking much about it. So every drug has side effects. So the key is, perhaps the key is making sure that if you're taking the drug, there's a reason for it. And one of the mistakes we do in medicine is we are very good at adding medications. We are not so good at taking those medications away. And I think every time we add something to the list, we have to maybe at least make an attempt. Can we delete something from your list so you don't end up with this long list of medication that perhaps you don't need? And then you end up with drug-drug interactions and other complications. So perhaps the key is not only talking to your doctor about those side effects, but also making sure that if we start a medication, there is a reason for it. It's not just, because we just want to go to the easy route. My philosophy in general, I tend to be very aggressive, if you wish, or proactive with the medication that we choose for your MS, for your disease-modifying therapy, to try to minimize the chances of anything bad happening to you. And I tend to be very conservative with the symptom management. I try to favor things like exercise, massage for spasticity, aquatherapy, psychotherapy over pills. And the reason for that is there is something about actually doing those activities that actually by itself is beneficial.
Next question's over here.
You were speaking earlier and you said the phrase tip of the iceberg. Okay, if the iceberg is below the water level and you are not having any enhancing lesions and have not for many years, so is progression due to more of the iceberg being exposed?
Great question, and you're clearly listening, because it's true. And what we know with MRIs, and there are certain advanced MRIs techniques that are only available for research. And when we look at those techniques, you can see that there is demyelination, for example, outside the lesions. So we looked at an MRI before, and you saw those white dots, and I told you, well, this is areas of demyelination, and that's true. But what about the rest of the brain? Well, MS patients, even in the areas that appear normal, there is loss of myelin, something that now has a term for that, something called normally appearing white matter. So MS patients have also demyelination there, and you can't quantify that on these MRIs. But if you do special techniques, MTR and DTI, you can actually see that and measure that. So there is a lot of below the water level damage that we know that MS patients go through. And that's why if you see something that is happening that is new, like a new lesion, you should act, because you know that that's the tip of the iceberg.
No, you what? Okay. Anybody have a question on the other side? Great. While I get there, Doctor, can you explain to everybody the importance of clinical trials?
Yes, absolutely. So clinical trials are a way for us to understand the disease better, to understand new therapies, how these therapies actually can affect MS, and in general actually know more about MS. And we never thought of MS as a B-cell therapy, a disease, right? When I went to med school, I always learned about MS saying it is a white matter disease, and the damage is triggered by T cells. And then when I went to fellowship, I learned it's not just the white matter disease, also affects the neurons, also affects the gray matter. And when we do high field MRIs, you can see lesions in the gray matter. And recently we learned it's not just a T cell disease, it's a B cell disease. When you look at ocrelizumab or other therapies, stopping B cells almost stops MS. So, and we learned that through clinical trials more than anything. So clinical trials is a wonderful way to test for new medications. If you want to go to a trial, make sure that you talk to your doctor, because like anything, as we mentioned before, there are risks. And the big question nowadays that you have so many options for your MS is, do you need to be on a drug that we still don't know much about? And that's the conversation that you should have with your doctor, right?
Great.
Sharon had a question here.
No, she had something that she wants to tell everybody later, but we'll do that later on. All right, so the next one, though, is the importance of what you can tell the people about what they've heard about stem cell treatments outside the United States versus what's really happening.
Yeah, so that's a very popular question, and I think we all share this excitement on stem cells. I think conceptually it's something that we hope it will result in some benefits. There are two lines of research now in stem cells for MS. One is what we call the hematopoietic stem cell research. Basically, that's a mouthful, but what that tells you is that those are the cells that later will become immune cells. So if you can pretty much reboot your immune system by causing something called immunoablation. You give medications to patients in which you just kill all these immune cells at once, all of them, T cells and B cells and everything you can think of. And before doing that, actually, you take some bone marrow cells, some cells from your bone marrow, your own stem cells, and you put them aside. So then you kill all these cells, and then you put those cells back, and almost like rebooting your computer, right? When your computer is completely frozen, at least what I do is just unplug it and plug it again, or reboot it, right? So that's the same concept. So that area is showing some benefits. There are now multiple centers in the US and in Canada doing research on that, and there is some trend of benefit. It's still not at the level of complete remission of MS, but it's something that we want to watch that. I think what Stuart is going after is the potential risk of doing any of these things outside a controlled study or something that actually you understand what the risks are, because as you can imagine, there are a lot of risks of doing this type of procedures. And I always try to caution my patients, at least, on saying, well, be careful what you're getting into, because we yet don't know. The other line of research in stem cell is perhaps not as advanced, but is fascinating, which is isolating cells that are actually skin cells or any other tissue type cell, de-differentiate those cells into a very primitive stage, going all the way down to the pluripotent state. So you pretty much get a skin cell and put that into a culture and make that cell behave as a primitive cell that has the potential to be developed into any type of cell. And then you put that cell into another culture and manipulate that to develop into myelin-producing cells. And then you can inject those cells into animals and see whether you can remyelinate. So that's fascinating. It's not yet at the level of humans, but it's something that we are hoping that will bring into one of the many options now that we hope that we can actually help to remyelinate and repair.
Anybody have a question yet? I could keep going. Oh, there we go. Over there first.
So what is the difference, like you said, doing the stem cell? If you're still removing something from your own body that has your own cells, why wouldn't it just turn back into the same thing?
Yeah, so great question. We don't know why immune cells in MS become autoreactive. However, we know that it's not a simple single process, right? It's not that you have one gene and that's it. And then you have that, no matter how many cells you have, they're all going to be autoreactive. We know that it's not as simple. So there are multiple things that had to happen in coordination that lead to this storm. So the concept behind that is that if you removed all these autoreactive cells that are talking to each other and constantly influencing each other, you almost bring it back to a state prior to whatever that event happened. We do also know that in MS there is an environmental factor that triggers all of that, whether it is a virus, whether it is vitamin D deficiency. We don't know what that is, but there is an interplay between the immune system and the environment. And the thought is that if you can almost reboot back to prior to that event, as long as you're not exposed to that event again, it should be fine. So it's a theoretical model. It hasn't been proven yet, but the basis for that is it's pretty much around those terms.
Any question here?
What is the status of remyelinating medications, and what is the most conservative estimate for how they will behave in a human?
Yeah, so there are now many therapies to help remyelinate that are being studied at different levels of clinical trials. Perhaps the most advanced is anti-LINGO therapy, which is again is an antibody that is going to block a protein that we all have called LINGO. That the only function of that protein is to stop myelination. So we all go as we grow. when we were babies and then we become teenagers, you have to myelinate and you have to grow, your brain grows and you're learning and you're doing all the things. But at some point that has to stop, otherwise your brain will continue to grow, right? So in our 30s, this lingo protein gets activated and the only function of that protein is to stop normal myelination. So researchers have thought about, well, what if we block that protein in MS patients? Can we enhance myelination? And they've done that in animal models and look beautifully. They did in mice and they stopped lingo and they demyelinated and these mice remyelinated. And then they went to humans. And the clinical study was done in patients with optic neuritis. And unfortunately, it didn't meet the outcome that we were all expecting, which is remyelination. But when you look at the study design and what outcomes they chose, perhaps there were ways that they could have done the study better. And we are still hoping that the company will continue their efforts. As a matter of fact, I believe they are doing that to bring that back to attention. There is a lot of other medications that are kind of like a refurbished indications for anywhere from phenytoin to antihistamines that are being studied that have promise in terms of remyelinating. So estimate, it's always hard to tell, but I will probably think maybe anywhere between now and 5 years we'll have something.
Okay, so if something is approved that is going to remyelinate, is it going to remyelinate everybody? And is it going to remyelinate people newly diagnosed? And what's the projection or what's the thought behind it?
Yeah, so another great question. So those are questions that are unanswered, but the feeling is, like many things in life, the earlier you intervene in life, the higher your chances of repair. So when you see pediatric MS patients, right, and we see that, in our clinic, you have kids with MS and they present with multiple problems, multiple symptoms. You do an MRI and you have 15 enhancing lesions, very different to an adult, right? They're very inflammatory. And then you do the same kid, you do an MRI a year later and they have 2 lesions, right? So they remyelinate very well. And that's why even though they get into trouble at some point, but they repair very well. And that's because their brain is very young. So anything that actually will enhance repair, it will work better probably the younger you are.
Does all this new repair study also include the repair of the broken axons?
Another great question, and that's something that we learned from the Lingo study, which is probably you need to have an intact axon in order to remyelinate, and that's another concept that and that actually makes sense. So if you want to build myelin, you have to build it over something. And going back to the wire, if you don't have the copper wire, it's pretty impossible to build the plastic around nothing, right? So having intact axons, it's key in order to enhance remyelination. And that's why today, even if we don't have those drugs available, what we can do is prevent patients to get black holes and prevent patients to have lesions.
Thank you for these answers. One more, another couple of good ones for you, or for the audience as well. MRI as a biomarker. What can you tell them about that?
Oh, I love the question. It's a great biomarker. So what a biomarker means is a tool that we can do that will reflect or represent what is happening in your body. That's what a biomarker is, right? A marker or a surrogate marker for something that is happening in your body. So if I check your blood sugar, that's a biomarker for your overall metabolism, how much sugar your body and your insulin is working and things like that. So that's an example of. So a brain MRI is a biomarker for brain integrity, tissue integrity, inflammation. So we can use the MRI for many things. We use that for diagnosis. We use that for prognosis, as I mentioned before. We use that to monitor therapies. We use that for safety. So MRI is a very powerful tool that allows us to have that window to look into the brain. As we alluded before, it's not a perfect tool, and there is a lot of things that are happening that actually don't get to the level that we can capture on MRI. So sometimes patients feel that they are getting worse, and you do an MRI, and the MRI is unchanged. So there is this paradox, and that's partially explained by the fact that we can't see everything on the MRI, but it's also explained by the fact that brain reserve is going down, and as we age, the ability of the brain to functionally compensate for disease goes down, and that's why patients clinically, they feel worse, even though the MRI is unchanged.
Thank you for that answer. You know, very involved with this whole industry. I could go on and all day and just treat this as a great crossfire, too. New question.
Why doesn't the brain just simply replace by, with its plasticity, why doesn't it just replace damaged or demyelinated axons with new axons moved around it?
Great question. Part of the reason, so axonal sprouting, think about axons as those wires, right? And at some point, as we were mentioning before, it has to stop, because otherwise the brain will continue to grow. However, the brain is very smart as creating more connections through dendrites or sprouting between axons and communication between axons. So think about these, going back to the analogy with the streets in Gainesville, okay? So think about these as, you have Archer Road, and all of a sudden you just stop the traffic there, and it's a permanent damage. There is nothing you can do for that. So axonal sprouting will be, okay, we don't have the money to build another Archer Road, right? We don't have the infrastructure. But what if we create collaterals to Archer Road and feed into different streets? And that's the concept of brain plasticity. So that's what the brain does very well. And let me tell you, how do you stimulate for that? How do you make the brain create these communications? By using the function that you lost. And that's the whole concept behind exercise. So if you lost function on your right leg and you're weak, if you keep stimulating that, you're going to stimulate your brain to create more collaterals and more connection. And that's why people who exercise, who do physical therapy, they do better, because you're giving a reason for the brain to improve. The brain is very plastic, and we're passionate about the brain. That's what we do for a living. But I do believe that it's the best organ. It's an organ that the more you use it, the better it gets. If you use your liver too much, you get cirrhosis. But if you use your brain too much, you get smarter. And whether it's through cognitive activities or through exercise, the brain gets better. And you're right, it's not perfect, but it could be better.
Any questions? Okay, here we go. Last one, all right? You're in a college town. I'm sure you walk around occasionally and you get that scent going through the air, right? What do you want to tell us about marijuana?
Like Don, our wonderful program coordinator, will say, this is a perfect question to end up on a high note, right?
Very good.
Marijuana. So it's a drug, like any drug. It's a medication. It's not approved, but take it as a medication. So don't think that because it doesn't require a prescription, it's safer. What I can tell you is that there is some evidence that may be beneficial for spasticity, though, as you know, the studies didn't show any significant effect on the actual metrics of measuring spasticity, but patients who took CBD felt better. I do have concerns in terms of chronic marijuana use and the potential negative effects on cognition, and I think we might, as a matter of fact, we were just approached to be a site for a marijuana study, and we are working to make sure that we can be a site, one of 5 sites in the US, and that's a very well-designed study, so hopefully we can offer that. But I do have to say that I have concerns in terms of chronic use of marijuana and cognition, so I'm being very careful and try to discourage people from using that as the only way of mitigating the symptoms, and perhaps trying other things prior.
Will you remember to do the study?
I'm sorry?
I'm joking. Another question, sorry. I have to.
Oh, sorry. So you mentioned about it's the CBD, not the THC, but you can get CBD from hemp, which has no THC in it.
That's right. That's right. And one of the challenges is, go ahead.
Excuse me one second. I have to back up on that. Decaf coffee still has caffeine, and what they call the different Coca-Cola products that's supposed to be not caffeinated, they still do have caffeine in it. And hemp does carry trace.
It's a trace.
Trace, correct. That's why it's still illegal in the federal government's concerned.
Actually, hemp is not. It's actually shipped across state lines. I'm in the business. So.
Yeah, no, perhaps I can back up. I'm not completely against marijuana, to be honest. The reason why we're doing the study is because we want to know about it and we want to learn. I'm just careful because many of the things that even in the studies that you hear may or may not translate to what you can get in a dispensary because it's not regulated. Even if the study was positive, what you can get perhaps is completely different to what the product of the study was done. So I'm just being overly careful.
CBDs can be bought over the counter at Whole Foods Market in all 50 states. There's no regulation on CBD infused foods.
Yeah. No, you're correct. It's still hard to make an argument that there is any medical benefit to MS beyond perhaps improving certain symptoms.
Okay, doctor, it's getting late. Thank you very much for coming
All right,
on down
thank you.
today. We appreciate it.